So here is our roadmap for today. First, classification and CT severity. Second, clinical management strategies. Third, a key clinical pearl. Fourth, a classic exam trap. And finally, a quick recall test. Let's get straight into it.
Section 1. Classification and CT severity.
Okay, so the Balthazar morphological grades basically represent a visual staircase of inflammation. We start at the top with a totally normal grade A pancreas. Simple enough, right? But as we move down, the severity scales up. Grade B shows pancreatic enlargement. Grade C introduces some inflammation and peripancreatic inflammatory changes. Grade D gets a bit more serious with one peripancreatic fluid collection. And then we hit the bottom, grade E. This is marked by 2 or more fluid collections, or the really ominous presence of gas in or adjacent to the pancreas. Take a quick mental snapshot of this, because it's the first half of our diagnostic puzzle. Next up, we have to evaluate the actual tissue death. The pancreatic necrosis score jumps up in 2-point increments, and it all depends on the percentage of necrosis you can see on the scan. So, no necrosis, that's 0 points. Less than 30% gets you 2 points. Between 30 and 50% scores 4 points. And if more than half the pancreas, so greater than 50%, is necrotic, you max out at 6 points. And this brings us right to our core formula. The math here is incredibly straightforward, but it's absolutely vital. You simply take that Balthazar morphology grade we just talked about and add it to the necrosis score. When you combine those two distinct factors, you calculate the definitive CT severity index, or the CTSI. That total score then neatly stratifies the patient's overall condition into 3 distinct actionable tiers. Now, since the max morphology score is 4 and the max necrosis score is 6, the whole index caps out at a maximum score of 10. A total score of 0 to 3 means we're dealing with a mild case. A score of 4 to 6 lands us right in moderate territory. And a score of 7 to 10, that signals a severe, high-stakes case of acute pancreatitis. Moving on to Section 2. Clinical management strategies. All right, so what do we actually do with this score? Well, for the green tier, representing patients with a lower CTSI and no significant necrosis, our strategy is entirely built on foundational supportive care. We're relying on aggressive fluid resuscitation to maintain perfusion, robust analgesia for pain control, and early enteral or oral feeding as tolerated just to keep the gut working. And of course, you always want to investigate and treat the underlying cause, whether that turns out to be gallstones, alcohol, or something else entirely. But what happens if that scan gets worse? If we see increasing fluid collections or worsening necrosis on the CT, we enter the yellow tier. And this demands close monitoring. You need to be hyper-vigilant here for dangerous complications. Specifically, we're assessing the patient for any signs of infection, monitoring for persistent organ failure, and definitely watching out for abdominal complications like an obstruction. The yellow tier basically means your patient is at a critical crossroads. Now here's where it gets really interesting. For the red tier protocol, so infected necrosis or symptomatic complications, we use what's called a step-up approach. We don't just rush the patient to the operating room. We escalate systematically. Step 1, you start antibiotics when an infection is either suspected or confirmed. If they don't improve on that, we move to Step 2, percutaneous or endoscopic drainage to physically get that infected fluid out. Only if that fails do we proceed to Step 3, a minimally invasive necrosectomy. Surgery is the absolute final step here, guys, not your first reflex. Listen, this point right here is absolutely crucial. Unless there is a confirmed infection or the patient is suffering from serious symptomatic complications, sterile necrosis should be managed with conservative supportive care. Just because the tissue is dead doesn't mean you automatically cut it out. Sterile necrosis stays out of the OR. Section 3, Key Clinical Pearl. We know that a Balthazar grade E shows the absolute most severe morphologic changes, right? But never, ever forget, the morphology grade does not equal the necrosis score. They are 2 totally different variables. The true clinical picture requires combining both of them into the final CT severity index. Section 4, Classic Exam Track. Examiners absolutely love to trick you with this, so do not confuse these 2 distinct concepts. A Balthazar grade E strictly equals severe morphological changes. However, a CTSI of 7 to 10 equals severe overall CT severity. A patient can absolutely have a terrifying-looking grade E morphology on their scan, but completely lack the necrosis necessary to push their final CTSI score into that severe 7 to 10 range. Always, always calculate the full index. Oh, and here's another classic trap. Seeing gas in a collection and instinctively jumping straight to the OR.
While gas strongly suggests infection, the ultimate rule of medicine is that imaging findings must always be married to the patient's actual clinical presentation. Treat the patient, not just the CT scan. Section 5. Quick recall test.
All right, let's test your retention right now. Imagine you're handed a CT read for your newly admitted patient. The scan shows 2 peripancreatic fluid collections, but absolutely 0 pancreatic necrosis. Think back to our tables for a second. What is the Balthazar grade, and what is the final original CTSI? Take a second, lock in your answer. Did you get it right? Let's break it down together. Because there are 2 peripancreatic fluid collections, that automatically bumps the morphology up to a Balthazar grade E, which gives us 4 points. But because the prompt stated there's 0 necrosis, the necrosis score is exactly 0. Add them together, and the final CTSI is only a 4. This beautifully demonstrates the exact exam trap we just talked about, a scary grade E morphology, but only a moderate overall severity index. As we wrap up this explainer, I want to leave you with a quick thought to ponder. How will you use the step-up approach to avoid premature surgery in your next acute pancreatitis case? Keep this structured logic in mind, calculating the true CTSI, relying on the step-up approach, and treating the patient rather than just treating the scan. And I promise you will navigate both your board exams and your next complex surgical shift with absolute confidence. Keep reviewing these concepts, and I'll catch you in the next explainer.